manuscript I co-led with my colleagues Emma Loshnik and Brianna Chang, titled The Reporting Completeness of SARS-CoV-2 Seroprevalence Studies, a project by SeroTracker. So I'll begin by introducing what SeroTracker is. SeroTracker is a knowledge hub housed here at the University of Calgary, created in the spring of 2020 in response to the COVID-19 pandemic. Sero means antibody. Antibodies are the proteins in our bodies that bind to invaders in order to fight off infections. So SeroTracker, we track antibodies. Why is this important? This little iceberg diagram demonstrates that. We all remember in the early stages of the pandemic when the news was constantly reporting on how many cases were confirmed in the city, province, country, and worldwide. Those were viral tests diagnosed by PCR swabs. However, when it comes to understanding COVID-19 immunity, these are only the tip of the iceberg. What this doesn't account for is cases that were not severe enough to get tested, so they fell under the testing radar. Asymptomatic infections where people didn't even know they had COVID, and people who just didn't have access to COVID-19 testing, and more recently, vaccinations. So Sero's surveys reveal this, allowing us to take a more holistic approach to understanding COVID-19 antibody prevalence. So here's a snapshot of the dashboard we have where you can take a look at the seroprevalence rates of different regions all over the world on serotracker.com. The issue at the beginning of the pandemic was all these important Sero surveys were published through a hodgepodge of news reports, government reports, journal articles without a unified data source. SeroTracker was created to be that unified data source, and here it is. Important bodies such as the government and international health agencies use this data to inform public health policy measures like healthcare resource allocation, school closures, and mask mandates. However, not all of the data we get is fully complete and easily understood in these Sero surveys. Take a look at these 3 words here. These are 3 different ways to describe malaria in Zambia. This is why standardized reporting is so important. It's a great example of how important it is to agree on different definitions and meanings between different disciplines and people in order to get comparable results. Otherwise, things get lost in academic translation. So we know that standardized reporting strengthens the ability of observational data to be interpreted and compared. The need for standardization is demonstrated by study reporting heterogeneity. So the WHO, in response to this, created the strengthening of the reporting of observation studies in epidemiology, or the STROBE guidelines. And so the reporting of Seroepidemiologic studies SARS-CoV-2, or the ROSES S guidelines, were developed as an extension of STROBE to address SARS-CoV-2 seroprevalence study reporting heterogeneity. Changes in reporting completeness over time, before and after the publication of ROSES S, had yet to be established. In other words, did this guideline help standardization work? So our research objectives were firstly, to understand reporting completeness of SARS-CoV-2 seroprevalence studies over time, so before and after the publication of ROSES S. Secondly, the uptake of ROSES S over time. Did these studies actually say that they were using the ROSES S guidelines? And lastly, the correlation of study characteristics such as location or adherence to another guideline with reporting completeness. And so here are our condensed methods. We used the existing SeroTracker database to get our Sero surveys. We used 199 of them, and we used a binary scoring system to measure adherence to the ROSES S guidelines. So this is how we did it. This is a snapshot of the ROSES S guidelines, and we either graded it a 1, a 0, or not applicable. And so our results were suboptimal percentage adherence. We found 48.1% median adherence. This is poor reporting completeness amongst SARS-CoV-2 seroprevalence studies. And so the implication is how SARS-CoV-2 seroprevalence data is interpreted and synthesized. We don't know the reliability of this data. Secondly, study characteristics were associated with reporting completeness, and there were no significant changes before and after ROSES S guideline publication. This will inform recommendations to improve reporting quality, standardization, and reproducibility amongst SARS-CoV-2 seroprevalence studies. As for acknowledgements, I'd like to thank my supervisors and coworkers at SeroTracker, including Mairead Whelan, Tyler Williamson, Nicholas Bobrovitz, Reza Husseini, Harriet Ware, Xiaoming Ma, Jane Young, Christian Cao, and Paul Ronksley.